friends, I hope I'm audible and visible. Let me very quickly check if my audio video is all fine. Can you all give me a quick thumbs up if my audio video is fine to all of you? So let us begin with today's session, and I am Dr. Chesta, your NEET PG educator on the best online platform, that is Unacademy. Now I have myself scored All India rank 261 in my NEET PG entrance examination. We are currently going on with an offer that is a Republic Day celebration offer. So for the 25th, 26th and 27th, we are offering a 6-month subscription for free. So if you get an Unacademy subscription of 1 year and longer plus subscription using this code CHESTA10, you will get 10% additional discount. So you have to use a code for this, and the code is my name, CHESTA10, and you will get 6 months extra for free. These are some of our learners who have cleared FMG exam, so congratulate to each and every one of them. We have free live test calendars for the month of January. I request everybody to please follow this. We have plus subscription which give you an access to Unacademy live classes from the top educator, and we have iconic subscription which give you an access to both Unacademy and Preplan. We do have a lot of special classes, so if you have Unacademy, use this code CHESTA10 and watch my free live classes. I do take session every day at 3 p.m. You can download the Unacademy learning app and you can watch this free set of questions, as well as we have a lot of paid questions, around 25,000 plus. We have a feature which is known as the raise a hand feature, so if you have any doubt you can just click the raise a hand feature. Focus FMG batch, where we have a 5-month batch which we will be discussing about a lot of MCQs. We have a target NEET PG batch where we have a 2-month batch with respect to the MCQ discussion, and also we have an ultra fast revision batch starting on 27th. I request all of you to please be a part of it. I will be taking dermatology classes here, so requesting each and every one of you to please be a part of Unacademy. You can take a shorter subscription of 2 months using my code CHESTA10, and this will give you additional 10% discount on it. So let us begin with today's questions. We have a very interesting set of questions with us. So let me very quickly start with some must know MCQs for the exam. Welcome all of you, and please try to answer this question. Which of the following statement about the oral lichen planus is false? Oral lichen planus is the most common autoimmune condition of the oral cavity. Dental amalgam. Then we have stress as the causative factors. Malignant transformation never occur, and the reticulate pattern is the most common type. So this is very commonly asked question. Can you tell me what is the answer? Which of the following statement about oral lichen planus is false? Oral LP is the most common autoimmune condition. Dental amalgam and stress are the causative factors, and malignant transformation never occur. Very nice, Marzina. Now this question we have already discussed in the past. Please remember, lichen planus is a very important topic, and there is a high probability that this question can be asked again. The correct answer of this question is option number 3, that is malignant transformation never occurs. There is a variant of oral LP which is known as erosive oral LP, erosive or atrophic oral LP. It has a risk of malignant transformation. So you cannot say that oral LP never transform into malignancy. That is a wrong statement. It is the most common autoimmune condition, true. The dental amalgam and stress are the causative factor, and reticulate pattern is the most common. Moving to the next question. In which disease do you most commonly see these hypopigmented macules? In which disease do you most commonly see these hypopigmented macules? Neurofibromatosis, tuberous sclerosis, Darier's disease, or Hailey-Hailey disease? Again, a repeat question. Very recently we have done this. You can have an additional findings in these individuals like presence of mental retardation, history of seizures or epilepsy. You can even have some bumpy lesions on the face in addition to these hypopigmented changes. So I'm giving you a lot of hint. Bumpy lesions on the face, which is nothing but adenoma, sebaceum or angiofibromas. Very nice combat Marzina. The correct answer is option number 2. And if you have attended my 3 p.m. session, I have told you that the tuberous sclerosis is also known as bone willow disease. Scarring alopecia, again this question we have asked already. Scarring alopecia is a feature of Lichen planopilaris, Lichen planus pigmentosus, Lichen planus pemphigoides or actinic LP. The correct answer is option number 1. Now the Lichen planus have a various variants. The one which occurs on the scalp is known as Lichen planopilaris, and we also have a syndrome associated, that is Graham's little Picardy syndrome. Graham's little Picardy syndrome is a syndrome associated with scarring alopecia. Now there is a lot of features. It is actually associated with Lichen planus. You have scarring alopecia on the scalp. You have non-scarring alopecia on the axilla. Non-scarring alopecia in the axilla. And you have follicular or papular lesions on the occipital part or the nape of the neck. Papules on the neck. So this is a very classical syndrome which is associated with Lichen planus. Try to remember this, although I have not seen many questions being asked on this topic. Now identify the false statement in management of Lichen planus. Combat Marzina, can you tell me the answer here? Identify the false statement in the management of Lichen planus. Oral steroids are the mainstay of treatment. Retinoids has been used. Intralesional steroids are indicated in hypertrophic LP, or systemic therapies are not commonly used. Good evening to all my students. Welcome Achan, Combat, Marzina. This is a question where the false statement is oral steroid is never the mainstay. It is the topical steroids which is the mainstay of the therapy. We give systemic therapies only when we have severe extensive Lichen planus which is not being controlled by the topical therapies. So mainstay is never oral, it is always topical steroids. Now this question is the last question where we have finished yesterday, I think. So the disease shown in the image is associated with, I hope you can easily make the diagnosis. It's a case of Lichen planus. You can see the cutaneous lesions, you can see the oral lesions, and please remember the answer to this question becomes option number 4, because Lichen planus have a lot of associations with this. Moving to the next question. Herald patch appears after the cutaneous lesions of pityriasis rosea appears. Can you tell me the answer here? Anybody can tell me the answer of this question? Herald patch appears after the cutaneous lesions of pityriasis rosea appears. Anyone can tell me the answer here? Achan, Marzina, Combat, very well done. Herald patch after the cutaneous lesions of pityriasis rosea heals. Please remember, it is a false statement. What is the progression of disease? In pityriasis rosea, first of all, patient develops a constitutional symptom, and the next feature is there is a development of a patch which is known as Herald patch, and it is also called as mother patch. Please remember, mother comes first, right? So mother patch will appear first, followed by, after a gap of 2 to 3 weeks or 2 to 12 weeks, patient develops what is called as daughter patches. Patient develops what is called as daughter patches. Okay, so there is a difference in Herald patch and you have daughter patches which develops. They are multiple and they are distributed on the body in the form of inverted fir tree or Christmas tree appearance. So the correct answer of this question becomes option number 2, false. Clear hai? Okay, can you all give me a quick thumbs up? The word eczema means, okay, although this is not a very important questions for you to be asked, but please remember eczema, it means to boil out. Now why we are saying this, because the most common histopathological feature, histopath feature of eczema is spongiosis. And what is spongiosis? It is nothing but intercellular edema. So this edema fluid sometimes oozes out of the skin and it appears as if there is boiling of the skin. So word eczema means to boil out or to ooze out. Okay? Next question. This is a feature of. These all are very important images and high probability questions for the exam. This is a feature of lichen striatus, chronic eczema, lichen planus, or all of the above. Anyone? Achan, Marzina, Combat. Anyone can tell me the answer here? Very nice. This is a classical description, or the correct answer to this question is option number 2, that is chronic eczema. Please remember, in chronic eczema you get what is called as lichenification. Understood all of you what is lichenification? Can you give me a quick thumbs up if you have understood this question? I think, am I audible to all of you? Yes. Now lichenification means there is a triad of increase in thickness of skin, increase in skin thickness, you have increase in the skin color, and what is the third one? Increase in skin thickness, increase in skin color, and a third very important point is increase skin markings. And all these three features occur when you have chronic eczema on your skin. So the correct answer is option number 3. And in which layer of the skin you see the changes? It is mainly on the lower layer, that is stratum malpighian actually, basal and spinosum together. Vesicles such as grain of boiled sago is characteristic of. Anyone? Shrishti, Achan, Marzina, Combat, Chandani, Achan, Sunny. Vesicles such as grains of sago is characteristic of. Very nice, all of you, amazing. Okay, Ji, the correct answer of this question is pompholics. Whenever you see fluid containing, clear transparent fluid containing vesicles on the palm, specifically the sides of the finger, this is known as pompholics or dyshydrotic eczema. Dyshydrotic eczema. It is pompholics or dyshydrotic eczema. This condition occurs due to, so it's a very simple image based question. You can see an image of the scalp where you have thick scales. Can you name this condition? What is it called as? Thick yellowish scales in a newborn or in a young infant. What is it called as? What is it called as? Yes, this is cradle cap. Now please remember, what is this cradle cap? It is actually the seborrheic dermatitis of infant. In infant, seborrheic glands are not active because seborrheic glands requires androgen for its growth. But sometimes because of maternal hormones or maternal androgens, the infants and the sebaceous glands become active. But these lesions heal spontaneously because the androgens they are washed away from the circulation over a period of 1 to 1.5 months. So this is a case of infantile seborrheic dermatitis, which is popularly known as cradle cap. Eczema which can lead to this condition is all except eczema which can lead to this condition is all except seborrheic dermatitis, phytophotodermatitis, nummular eczema. Very nice, Marzina. Then we have Shashti, Sunny, Manasa, Chandani, Achan. So eczemas which can lead to these conditions are all except. The correct answer is nummular eczema. Now I would request all of you to please have a look on this image. What this image shows. This image tells you that there is generalized erythema and exfoliation of the skin, and this is called as exfoliative dermatitis or erythroderma. Exfoliative dermatitis, or it is called as erythroderma. Now the question is, which among the following will never convert into the exfoliative stage? The answer is nummular eczema. Atopic dermatitis, seborrheic dermatitis, phytophotodermatitis, they can all progress to the end stage in the form of exfoliative dermatitis, but nummular eczema will never reach up to that state. So try to remember this question, very important for your exam. Allergen responsible for this condition, I think it's a very clear cut image and the question attached to it. Can you tell me what can be the answer here? This is, you can see that here in the image they are performing the application of dye on the hair. So post application of the dye, he developed erythema, exfoliation of the skin and edema of the face. So it's a clear cut case of hair dye induced lesion. Very nice. The answer is paraphenylenediamine, that is PPD is the component of the hair dye which causes allergic contact dermatitis. Now look at the image. This image we have discussed in the histopath session also. Just mark the dermoepidermal junction and you can see that the pathology lies over here. There is intercellular edema, what is visible here. Intercellular edema. Anyone? Manasa, Gurang, Achan, what is the correct answer? Very nice. The correct answer of this question would be, this is a feature of acute eczema. And what is this? It is spongiosis. What is this? It is spongiosis. Clear as Sunny, Manasa, Marzina, then we have Shashti and all my dear students. Coin-like lesions are characteristic of. Again a very beautiful image and very interesting because here you can see small round discoid lesions, disc-like lesions. If you want, I can just elaborate this. We do not see such a beautiful image every time. So you can see that there are round circular lesions mainly present on the extremities, disc-like lesions. So they are coin-like or disc-like, or they are round lesions. So this is a very classical feature of. Okay, Shrishti, ma'am, please explain the histopath. Definitely I'll do that, don't worry. So the answer to this question is nummular eczema, or which is also known as discoid dermatitis. It is mainly seen in the extremities of young or middle-aged male. You have uniform lesions in a disc-shaped manner. Now, for histopath image, I always ask the students to mark the dermoepidermal junction, which is this one here. Now I'm elaborating it. Now, one thing which is clear is that the pathology is inside the epidermis. Can you see? This is absolutely normal. The dermis is absolutely fine, but the problem is in the epidermis. Now compare this part from this part. I hope you can appreciate this white areas in between the two cells. So here the cells are in close proximity with each other, but here you can see that there is stretching of the cell. Something is pushing the cells away from each other, and this is actually transparent on the histopath image because this is fluid. So this is a very classical intercellular edema which you see in the patients of eczema, and this is also known as spongiosis. Clear ho gaya? I hope this question is easy for you. Can you give me a thumbs up, Shrishti, if you have understood this? Now another question, I think it's a very easy one. Tell me that the action spectrum of UVB rays is not a derma question. Actually, not a question which you usually uh, get to ask in your NEET PG exam. But yes, it's a UG type of a question. Can you tell me what is the wavelength of UVB? Anyone? Okay. So let me help you. 400 to 700 is visible. The longer wavelength is visible. Okay. So 400 to 700 is the visible spectrum. VIB we tend to see, right? Now less than 290 is actually UVC. 290 to 300 is UVB, and 320 to 400 is UVA. So that is how we have divided the action spectrum of ultraviolet rays. Clear? I think it's a very simple question. The answer to this question becomes option number 3 because they have asked UVB. So that is what the shortest are the gamma rays and X-rays, and the longest are micro and radio. You all must be thinking that, ma'am, why you are giving us these questions? Because they tend to ask you these questions. UVA belongs to what rays and visible? Because if you remember, Wood's lamp actually depends upon this principle. Window glass blocks which of the following rays? Window glass blocks which of the following rays? Anyone? Anyone can tell me the answer here? Please remember, the glass of the windows blocks UVB. Now why it is important? Because UVB has the maximum risk. See, UVC is the worst, UVC is actually the worst type of the rays, but it is almost 100% reflected back by the ozone. So we are usually not worried about UVC. But if it penetrates, it is the most risky wave. The one which penetrate is UVA and UVB. 90% of the UVB is reflected back by the ozone. Only 10% enters. And this 10% is responsible for skin burn and malignancy. All the malignancy potential you have is because of UVB. And UVA, it is 90% entered and only 10% reflected back, and this is responsible for skin, for what? Skin tanning. So why it is important? Because like if you are having a glass on the window, like if you are going in a car and if you have glass in the window, you can only get skin tanning, but burning of the skin and malignancy potential can be prevented, because UVB is responsible for both these features, and UVB can be reflected back by the glass window. Did you all understand this feature? Very very important. If you have understood, can you give me a quick thumbs up? And yes, you can also remember it as B is bad. Chalo, the next question is here on your screen. A 25-year-old man presented with rash, which is with burning sensation. So we have a sunburn patient here. You can see clearly that the undergarment area is spared and the remaining part shows a very characteristic sunburn. So the answer is, or the question is, which part of the UV spectrum is responsible for this type of reaction? We have just now discussed this part. Yes, so sunburn, look at this. Sunburn is actually a feature of UVB. So here we have a patient with sunburn, so the answer should be option number 3. A कहाँ से आ गया भैया? UVA is skin tanning. So I think you all got confused. I've written this for UVB. So UVB causes skin burn as well as it causes malignancy, while UVA is responsible for the tanning of the skin. Clear all of you? Manasa, Shishti, Achan, all my dear students, can you give me a quick thumbs up if this is clear? Chal, amazing. Skin crease, upper eyelid and retroauricular space are involved in which of the following condition? Skin crease, upper eyelid and retroauricular areas are involved in which of the following condition? Chronic actinic dermatitis, airborne contact dermatitis, irritant contact dermatitis, or atopic dermatitis. Pancake, you don't need to know the entire spectrum of UV, but UVB, why it is important? Because yes, it is responsible for the sun burn and malignancy. And the second is it is whenever they ask you the questions related to Wood's lamp, the wavelength is important. And if you remember, I've told you that in Wood's lamp the wavelength is 365 nanometer, okay, or 3 yes. So because of that, it is in the UVA spectrum. So there it becomes very important. Okay, ji. Fine. Okay. Clear with this question? The next question which is on your screen, can you give me the answer here? Okay, ji. The correct answer of this question is the skin creases means the skin fold. Skin fold means the flexural areas. If it is flexural areas, it has to be something which is running through the air, and that is why it is airborne contact dermatitis. Chandani, please remember that the sun-induced, the actinic or the sun-induced lesions, they usually occur over the exposed part, extensor part. But here they are clearly mentioning that it is the flexural areas, and that is why it is airborne contact dermatitis. It is not atopic dermatitis. Atopic dermatitis, for labeling it, you should have what? Major and minor criteria. And if you remember, Rajkas and Hannafins have said that you should have pruritus plus 2 major or 3 minor criteria. 2 major or 3 minor criteria, if you remember. Okay, so pruritus plus 2 major or 3 minor criteria, but that is not given here. Nothing is mentioned other than one point, that is there is skin lesion, and that is why we are not picking the atopic dermatitis. Clear? Any confusion? Okay, Manasa, it's a very long topic and we cannot discuss dermatitis just verbally. So I would request you to please attend my plus class, which I am starting on 31st. I would be discussing the dermatitis in detail. 31st January I am starting with the plus course. Please use my referral code CHESTA10 and get Unacademy subscription. So here is the difference. Oh, okay, so I have an image. Look at this image. So if you notice that the periocular region, just below the nose, just below the lower lip and in the neck, all these areas are spared. This is how you get photodermatitis. But here you can see that most frequent involvement is flexures or the whole face, neck. This is how airborne contact dermatitis patient presents. Okay? Next question is on your screen. Next question, please answer this. Anyone? Yes, so here a 36-year-old female with itchy rash on the extensors. Now here they are present on the exposed part, and if it is at the exposed part, it has to be photodermatitis. Is that clear? Okay, so this is a very classical. Okay, I don't know what conversation is going on between the combat healer and I don't know, some more person, Pancake. I think it's best if we concentrate here on the today's class. ठीक है जी, चलो. So 45-year-old alcoholic male presented with the erythematous to hyperpigmented scaly plaques over bilateral hand and feet of 3-week duration. There was a clear demarcation between the involved and the uninvolved skin. Which of the following is the correct answer? Anyone? Now again, a very well defined rash in a patient who is alcoholic tells you that you are dealing with a patient with pellagra, which is vitamin B3 deficiency. And this is a very characteristic photodermatitis which you see in a nutritional deficient individual. Next question. "55-year-old male presented with its itchy lichen-flied hyperpigmented plaque over forehead, cheek, nose, V area of the neck. There was sparing of upper eyelid and skin creases. He gave history of photosensitivity. The likely diagnosis would be," the answer here is actually option number 4, and there should be chronic actinic dermatosis, which is the correct option here. Photodermatitis and actinic dermatitis are same things, but when they develop lichenification, it should be chronic actinic dermatosis, which is the correct answer. Very nice. Next question. What is the correct answer of the next question? 70-year-old female with pruritus, eruptions on her lower abdomen, thigh since 10 days. There was a tense bulla on the erythematous base, oral erosions. Nikolsky sign is negative. Which of the following is the correct answer? Why not atopic, ma'am? Okay, in atopic dermatitis, again, there should be a classical history which should be given, right? Can you tell me any point which favors the diagnosis of atopic dermatitis? Are you able to fulfill the Rajkas and Hanafin's criteria here, Pancake? You can only fulfill if I consider it as a chronic condition. So you can just fulfill the feature of the chronicity, the feature of the lesions. That's it, nothing else. Okay, but chronic actinic dermatosis is something which is more eligible for this answer. Okay, now? Yes, definitely. There should be positive family history. That is one of the major criteria. And the history would be, see, 55-year-old patient suddenly coming up with a history of eczema. You will not keep it as atopic dermatitis, because atopic dermatitis is something which starts very early in the life. So you cannot diagnose somebody who presented in the age of 50 with the features as diagnosis. No. Okay, please remember, that is very important. You may not get the history of asthma or family history in all the atopic patient, but something which is very important is the disease have started in the elderly. That is something against atopic dermatitis. Clear hai? Who have asked that question? Pancake, can you give me a quick thumbs up? Take it. Now here the answer is bullous pemphigoid, because a 70-year-old female with itching, presence of tense lesion, and there is eosinophils and subepidermal blisters, all point towards the answer option number 4. What is the gold standard test for diagnosis of epidermolysis bullosa? What is the gold standard test for diagnosis of epidermolysis bullosa? Histopathology with hematoxylin and eosinophil, transition electron microscopy, direct immunofluorescence, or ELISA. What is the gold standard test for diagnosis of epidermolysis bullosa? Derma is very tough and confusing. Okay, so pancake, trust me, it is not the case. Only when you don't know dermatology, it becomes little confusing. I would request you, or I would actually recommend you to please take 1+ course with me. You can take the Unacademy subscription using this code CHESTA10 for 2 months, because that is the minimum subscription which we provide right now, which is around 6750 rupees. I am starting with a derma course on 31st of January. I would actually recommend you to attend this course, which is of I think 10 hours, quick revision of derma. It will actually help you a lot. If you're targeting NEET PG, if you're targeting NEET PG 2022, this is the best test or best exam which you can give. Okay? Now the correct answer is electron microscopy. Very correct, Shrishti, that you cannot do DIF because there is no autoantibody. If there is no autoantibodies, you cannot. Understood? Can you give me a quick thumbs up, all of you? Yes or no? I cannot see anybody's comments. Yes, good. Drug of choice in a treatment of dermatitis herpetiformis would be, what is the drug of choice for dermatitis herpetiformis patients? Prednisolone, mycophenolate, mofetil, I think it's an easy one. Depson, azathioprine. Yes, the drug of choice is Depson, but what is the treatment of choice? It is to avoid the diet containing bro. And what do you mean by bro? It is barley, rye, oat and wheat. Clear hai all of you? Okay. Shrishti, is it MCQ based? Yes, Shrishti, the session will be MCQ based, and you would be taught the theory part with respect to the important topics which has a higher probability of being asked. So the session which I will be starting on 31st, very important. And in addition to derma, we have all the 19 subjects and all the great educators will be teaching you. So best thing for your quick NEET PG 2022 division. Okay, chalo. Okay, please remember, pancake, it is not rice, it is not rice, it is rye, it is not rice. Okay, rice you can give in the patients of dermatitis herpetiformis, so don't get confused. You can easily give rice. They are not at all allergic to rice. Yes. So BP180 is the target antigen in all of the following autoimmune bullous disease except. We have done this question few days back. Yes, the correct answer is option number 3. What is pemphigus foliaceus? Anyone? What is pemphigus foliaceus? Pemphigus foliaceus, the IgG antibodies is against what? It is against BP. No. Desmoglein 1. Very sorry, it is not because of BP, it is desmoglein 1. Okay? While in mucous membrane pemphigoid, in bullous pemphigoid and in pemphigoid gestationalis, you all see BP 180 antibodies. But here we have IgG antibodies against desmoglein 1, which is present at the subcorneal level. Anchoring fibrils are made up of, again we have done this question recently. Anchoring fibrils are made up of, so I'm giving you a very quick answer because this is an easy question. So if you remember, like whenever I draw the basement membrane zone, if you remember that I draw basement membrane zone. So in basement membrane zone, what happens? You have stratum basale like this. So this is how you have your stratum basale layer. This is how you have your stratum basale layer. Now just below stratum basale you have basement membrane, and below the basement membrane you have dermis. Okay. If you remember, I have told you that there are some glues which are present in between. Can you tell me what is this glue which attach the two adjacent keratinocyte? Can you tell me what is this red color glue? Anyone here? What is this glue? This is desmosome. Okay. So the keratinocytes, they are attached to each other with the help of desmosome. Now the lowermost keratinocyte, it is attached with another glue to the basement membrane. So here we have another glue. So this glue holds the epidermis to the basement membrane. And can you tell me what is this glue? This is actually hemidesmosome. I hope you all can figure out what I am trying to tell. So all the keratinocytes, they are attached with the help of desmosome. And the lower part of the keratinocyte, in the last layer, it has another glue which attach it to the basement membrane. But how this basement membrane is attached to dermis? So we have a filament, or we have some fibers which pass from the dermis and it attaches itself to the basement membrane. And these actually they are anchoring fiber. They are actually anchoring the basement membrane or epidermis. So these anchoring fibers which are present in the superficial layer of dermis, they are actually called as collagen 7. They are made up of collagen 7. Is this clear? So these anchoring fibers are actually holding the skin or epidermis to the dermis, so that we do not have any aberrations or any such removal of the skin. Clear hai? Can you give me a quick thumbs up if this point is clear to all my dear students? Eosinophils on the zinc smear is a feature of yes, eosinophils are actually a feature of bullous pemphigoid. And because of these eosinophils, why there is eosinophils? Because of activation of complement. If you remember, when you do DIF in a patient of bullous pemphigoid, what do you see? You see IgG and C3 deposits. So these complement factors, they recruits eosinophil to the site of inflammation. So we have eosinophils in bullous pemphigoid more commonly. Which of the autoantibodies are commonly found in circulation in dermatitis herpetiformis patients? Anyone? Which of the autoantibodies are commonly found in circulation in a patient of dermatitis herpetiformis? Anybody can tell me the correct answer here? Very nice. The answer to this question is, this is also we have done. It is the anti-epidermal transglutaminase. So before moving ahead, I just want to explain little bit about DH. So what happens in a patient of dermatitis herpetiformis? Around 90% of DH patient has celiac disease. So just imagine that this is the intestine of the patients of dermatitis herpetiformis. What happens if a patient of celiac disease take a diet which is rich in gluten? Can you tell me what happened? So gluten containing diet, like if they have taken bro, so this will go inside the intestinal mucosa and will cause inflammation. They will produce gladine, which is the metabolic product. This will cause inflammation, formation of antibody against the gladine, and these inflammation will cause exposure of tissue transglutaminase. Now these exposed tissue transglutaminase will develop antibodies against them. IgA type of tissue transglutaminase antibodies are developed. Now these antibodies, what they will do, they will travel through the blood. So they will enter the blood from the site, and through the blood they enters the skin, because you know that blood goes everywhere, so it goes to the skin also. Now if you remember, in my basic classes I usually teach, when I teach the plus course, I teach the theory that the blood vessels are not present in epidermis. Blood vessels are only present till till the dermal papilla. So over this part of the dermal papilla, we have another antigen which is known as epidermal tissue transglutaminase. So what happens, these IgA antibodies which are actually formed against tissue transglutaminase, there is molecular mimicry and it reacts to the epidermal transglutaminase also, causing lot of inflammation only over the dermal papillary tip. And that is how you develop multiple grouped itchy vesicles or erosions. Itchy vesicles or erosions. And there is dermal papillary tip microabscess. Did you understood the basic problem? This is how the dermatitis herpetiformis patient presents who have a cutaneous or who have an underlying celiac disease, and how the celiac disease inflammation starts the process in the skin. So that is the complete correlation. Can you all give me a quick thumbs up if this is clear? Very important for your understanding. Very important for your understanding. ठीक है जी? Can you give me a thumbs up? Chalo. Which of the following cutaneous manifestation of tuberous sclerosis is present at birth? So again I am telling you, pancake, there are much more things which I can help you out in dermatology. Try to take my subscription if possible. You can use a 2-month offer. We usually do not give 2 months. We have a minimum 3 month only. But because of NEET PG, we have introduced this 2-month subscription of Unacademy. So please use my code and do not give up on dermatology. It's a very high scoring subject. And I'll make sure that I'll make this subject interesting for you. So please get your subscription today. Okay. So which of the following cutaneous manifestation of tuberous sclerosis is usually present since birth? Yes, the correct answer is ash leaf spot. Ash leaf spot is something which is present since birth. Okay, so let me see if we have any more questions. So this is the last question which we have today regarding the dermatophytic infection. Mark the correct option. Yes, Shrishti, I would be giving the quiz, but today because we have extended the class, so the timing would be little late. I think we can start it at 5:30. That is fine with you. 5:30 p.m. will start the quiz. Okay. So I'm just finishing off with my class. So I'll start with the quiz in the next 5 minutes. I hope that is fine with all of you. Can you do this last question? Can you do this last question? Yes, the correct answer of this question is there is central clearing which is present, and we have a keratophilic fungus. The correct answer is option number 1 and C. So dermatophyte is actually a keratophilic fungus which loves keratin. And keratin is only seen in the epidermis. It is not present in the dermis or in subcutaneous tissue. Whenever you develop a lesion, it is an annular lesion. It tends to spread from one end. It leaves one side and it enters to the next part. So it tends to spread slowly, and that is why the central area is clear and the margins are active. The nail changes are usually white in color. It is not red. So option number D is also correct. Okay. So the only correct option is option number C. Thank you all of you. I hope you have liked today's session. So I request everybody to please subscribe to this YouTube channel, that is Let's Crack NEET PG. You can also follow us on our Telegram group. The name is same. If you like the way I teach, and if you want to learn more derma classes, you have to use the code Chesta10. Where is the session on app? Is it for plus? Nahi, Pancake. I'm conducting a quiz right now, which is a free quiz. I don't know why I'm not able to share the link on the YouTube sessions, but you can quickly join a Telegram group with this name Let's Crack NEET PG. I will be putting that code in the Telegram group, so you can just go and pick up that code. And if you want, I can start the quiz little late also, but I'm targeting for 5:30 p.m. so that we can quickly start with the quiz and end with the 20 questions. So just go to the Telegram group name Let's Crack NEET PG. I will be very quickly uploading the code or the link of the